Hi friends, welcome back to my channel. Today I'm going to discuss all about skin cancers and what exactly dermatologists do in skin clinics. If you're new here, I'm Chris and I'm a junior doctor currently based in Glasgow in the UK. And on this channel, I share my life experiences working as a doctor in the UK. Just a disclaimer, this video is for educational purposes only and is by no means a substitute for medical advice or opinion. If you're worried or in doubt about your moles, please get medical help by seeing your GPs so that they can refer you to dermatology for a closer inspection. For those who don't know, skin cancers are broadly divided into three main types. You have basal cell carcinomas, which are a common slow-growing form of skin cancers that rarely cause harm in the long run. The other type is called squamous cell carcinomas. They are rapidly growing and are often due to chronic sun exposure. I'm not going to touch on BCCs or SCCs in detail as they are a whole new topic, but if you would like me to discuss more about them in future videos, do drop me a comment down below. So today I'm going to talk about melanomas, which is considered the most serious form of skin cancers in the UK. This is because they have a risk of spreading to other parts of the body. Now, you may ask, why is this important? Well, melanomas are getting more common in the UK, and it is estimated that over 16,000 people are diagnosed with melanomas each year in the UK. Melanoma is also now the fifth most common cancer in the UK. Melanomas arise from pigment cells in the skin, also known as melanocytes. Now, melanocytes produce the pigment known as melanin, which gives the brown or black moles that you see on the skin. Normally, the skin cells would grow, divide, and mature before dying and being shed from the skin. However, in melanomas, there is a mutation in the genetic structure. This causes the melanocytes to grow more rapidly than usual. The melanocytes also start to spread from the skin surface to other parts of the body, including the blood vessels. So the most common sign of melanoma is when you see your own mole become darker in appearance than usual. Sometimes you may also see a new mole appearing out of nowhere as well. What makes someone at risk of melanomas? The main risk factor to melanomas is chronic sun exposure. This includes working outdoors, having outdoor hobbies, as well as traveling abroad to sunny places. The use of sunbeds also increases one's risk of developing melanomas. The risk is also increased with age, so it's more common in older adults. People who have fair skin, red hair, and freckles tend to be more at risk than darker skin types. And this is because they tend to burn rather than tan easily under the sun. Other risk factors include having a weakened immune system due to infections or even medications, as well as having a family history of melanomas. Say if you have a mole that has changed in appearance and you have been referred by your GP to dermatology, what exactly do we do in clinic? Well, the first thing we do is to take a focused history, and this includes asking questions surrounding the mole itself. For example, when did you first notice the mole, how quickly it has changed in appearance, and what changes you've noticed. We also ask about risk factors for skin cancer as previously discussed, and this involves having bright lights with a magnifying glass in order for us to have a closer inspection of the lesion in focus. We also use a dermatoscope. Now, this is a small handheld device similar to that of a magnifying glass. It magnifies the mole large enough for us to examine the pigment network. Dermatologists often put either oil or gel on the device surface, and we hold it against the skin surface in order for us to have a closer look. Oftentimes, we also offer a full skin check during clinic to examine your other moles as well. If the mole looks benign or non-worrying under the dermatoscope, this is often reassuring and we won't do anything else. If it looks odd or worrying under the dermatoscope, we would then subsequently move on to do a biopsy of the lesion. We often will also offer clinical photographs of the lesion so as to get a baseline picture. Biopsy is done where we remove a small section of the skin, including the mole in question, as well as a narrow margin of normal skin around it. The sample will subsequently be sent to our laboratory for the pathologist to look under the microscope. This is often a day case procedure and will be done under local anesthetic. The doctor will firstly mark the area that they wish to remove. They would then subsequently inject the local anesthetic into the area in order to make the whole procedure numb and pain-free. The only pain you should feel is the local anesthetic needle. The skin sample will be removed with a scalpel and the wound will be closed with stitches. These can either be dissolvable or non-dissolvable depending on the situation. Dressing will be placed on top to cover the wound. The nurse and doctor will then subsequently let you know on how to take care of the wound. On some occasions, we may not necessarily need to remove the molds. We may take some professional photos in clinic and subsequently ask you to come back in a few months' time for us to re-examine the mole. If it has not changed in appearance, then it is reassuring and we will not do anything else. However, if it has changed in appearance when you return to clinic, then we will move on straight to biopsying the lesion. If melanoma is diagnosed, we will subsequently bring you in to discuss the biopsy findings and need for further management. Melanomas are categorized into 4 stages depending on their severity. Stage 1 being the earliest form of melanoma and stage 4 being the latest form. The staging system takes into account the thickness of melanomas and if there has been any spread of melanoma cells to other parts of the body. Stage 1 and 2 melanomas are only present in the skin and has not spread. In stage 3, the melanomas have spread to the nearest draining lymph glands, and in stage 4, it has gone beyond the lymph glands to other parts of the body. The staging system is made up of the pathology report, clinical examination, as well as any further investigation findings. All melanomas will be discussed in our skin cancer multidisciplinary team meetings. This consists of dermatologists, surgeons such as plastic surgeons, pathologists, skin cancer specialist nurses, as well as other specialties including oncologists and radiologists. Each melanoma patient should be given information as well as a point of contact with a skin cancer nurse specialist. Depending on the stage of melanomas, we may offer further investigations such as CT scans of the body as well as sentinel lymph node biopsy. This is an optional test where we check if the cancer cells has spread to the nearest draining lymph glands in the body. It is done under general anesthetic and has its own risks and complications. We only offer to patients with melanomas of a certain thickness due to the risk of it spreading to the lymph glands. For all melanomas, we would offer a full skin check to make sure that there are no other melanomas elsewhere on the body. We will also want to feel your lymph glands on the neck, armpits and groin, as well as feel around the tummy to make sure that there are no enlarged lymph glands or organs in the body. We often need to get a second procedure to remove more skin from around and beneath the melanoma scar. The second procedure is called wide local excision and is often done under local anesthetic. The margin of skin removed ranges from 5 mm to 2 cm, depending on the severity and thickness of melanomas. The idea behind doing this is to ensure that there are no remaining cancer cells left behind, as well as to minimize the risk of melanomas from recurring. Sometimes, depending on the complexity of melanoma scar, you may require a flap or a graft. This is often done by plastic surgeons who will give you the information if you require it. In late-stage melanomas, there are other treatment options available, and this includes chemotherapy, radiotherapy, as well as targeted treatments such as immunotherapy. The treatment offered will depend on the type of melanomas. We sometimes offer genetic testing as well to see if there is any specific DNA mutation in the BRAF gene in which certain treatments will work well against. So the first thing you need to do is to be able to monitor your moles and to seek help if you are worried about any change in appearance. We have the ABCD guide in order to help you monitor your own moles. A stands for asymmetry of your moles. This means if you divide your mole into half, the two halves are not similar in size or shape. B stands for border. If you notice the border of your moles look blurred or irregular, this is something a bit more worrying. C stands for color. Melanomas often appear in different shades of black, brown, or even pink. If you see 2 or more colors in your mole, This is something you need to speak to your healthcare professional about. And lastly, D stands for diameter. Most melanomas are often 6 millimeters or more in diameter. Another important thing that you can do for yourself is to protect yourself from sunlight. If you are a sunbed user, I highly recommend you to stop using it. Do you know that using sunbeds before age 30 increases your risk to getting melanomas by over 75%. Indoor tanning beds are proven to cause melanomas and has been classified as the highest cancer risk category by the World Health Organization. Here are some of the practical tips you can use to help protect yourself against melanomas. Number 1, avoid being outside when it's the sunniest, so between 11 to 3 o'clock in the afternoon in the UK. Number 2, use a broad spectrum sun protection cream with at least SPF 30 or more and reapply it as and when you need. Do you know that UV radiation from the sun is transmitted into 3 wavelengths: UVA, UVB and UVC. Fortunately, UVC doesn't penetrate the Earth's atmosphere, so we don't really need to worry about it. UVA is associated with skin aging as it affects the elastin in the skin, causing more wrinkles to form, and is also associated with skin cancer. UVA can penetrate through window glass and also more deeply than UVB in the skin. UVB, on the other hand, is responsible for causing sunburn and is strongly associated with melanomas. SPF is also known as sun protection factor. This protects against UVB but not UVA, and ranges from around 6 to 50. To protect against UVA, you will need the UVA star rating on the packaging. The stars range from 0 to 5, with 5 offering the highest protection against UVA. A sunscreen of at least SPF 30 with a star rating of 4 or 5 against UVA is generally considered good protection against sunlight. The third tip is to try and cover up with your clothing, a broad-brimmed hat as well as sunglasses, and this is to try to reduce exposure to sunlight. The last tip is to take a vitamin D supplement. Guidelines now recommend taking a 10 microgram vitamin D supplement for everyone during winter in the UK. Consider having your vitamin D levels checked if you are limiting yourself against strong sunlight. If you are found to be vitamin D deficient, you may require a higher dose of vitamin D supplementation. It is very important not to sunbathe in order to get your vitamin D supplementation. This is because you can still get your vitamin D supplementation through the occasional sun exposure, as well as certain foods including oily fish and fortified food. Thank you for watching this video on melanomas. If you find this video interesting, be sure to give it a thumbs up and leave a comment down below. I would love to hear your suggestions for future videos as well. Thank you for watching. See you next time. Bye bye.